Kia ora koto katoa. Welcome to our third session for the day. Thank you to our Facebook audience and our Zoom audience for joining in. This session is with the Health Communication Division, Health Communication for Closing Health Disparities. We will go through four papers that are slotted in this division that go all the way from looking at interpersonal communication, provider-patient communication, to understanding health information seeking behaviors, to the prevalence and perceptions of health behaviors and discursive constructions, to a culture-centered process of building voice infrastructures to address health disparities. So let's go to the first presentation. It's titled Disparities in the Patient-Provider Relationship, Investigating the Role of Patient-Centered Communication.
Hello, everyone. My name is Kelly Merrill Jr. I am a third-year PhD student at The Ohio State University, and I'm excited to present my research along with my collaborators, Kyla Brathwaite, Rachel McKenzie, and Dr. Shelley Hovick on this paper entitled Disparities in the Patient-Provider Relationship, Investigating the Mediating Role of Patient-Centered Communication. So the focus of this paper is on the patient-provider relationship. Historically, this relationship has been termed paternalistic or egalitarian, such that there was a restriction of freedom and responsibilities of the patient, where they only listened to what was provided for them from their healthcare provider. But more recently, we've seen a shift to more collaborative and patient-focused or patient-centered relationships, such that the patients had a larger role in their healthcare. Research also shows that healthcare providers are crucial for health promotion, disease prevention, and access to treatment. Thus, poor patient-centered communication, or PCC, here forward, can exacerbate health disparities. Thus, the goal of this paper is to not only investigate contributing factors of PCC, but also to look at some outcomes of PCC, thus highlighting its mediating role. So the Epstein et al. 2005 article highlights various factors that influence PCC, but this paper is specifically focusing on the patient factors that influence PCC. These are the individual characteristics that influence a patient's relationship with their provider. We specifically look at education, income, and race and ethnicity, such that less education, greater income, and those that identify as white compared to minority groups will report greater levels of PCC. We are also interested in a couple of PCC outcomes, or outcomes that are related to having a patient-centered communication type of relationship between the patient and the provider. First, being the general health of the patient. Research has shown that greater PCC is associated with greater physical and emotional health, as well as the quality of care, the perceived quality of care that the patient has, that they're receiving from their provider. And research also shows that greater PCC is associated with greater quality of care. Therefore, we present the patient-centered communication model, or the PCC model. This model actually draws from research on the structural influence model, which is an important theoretical tool for understanding the links between patient-provider communication and health disparities, such that health communication and health outcomes can be directly and indirectly affected by both individual and social determinants of health. So in this model, you can see that PCC is mediating the relationship between the patient factors and our outcomes of interest, general health status, and quality of care. Further, research does support that patient factors can influence both general health status and quality of care. So we propose direct relationships as well. For your convenience, I have provided all of the hypotheses that are presented in our paper. I will not go through them specifically, so you can pause and look at these in more detail. To test this model, we used data from the 2019 Health Information National Trends Survey. We're specifically interested in individuals that only identified as white, Black, Latino, Latina, Latinx, or Hispanic, so our final sample size only had 3,829 people. The average age was 57, ranging from 18 to 94, and we had slightly more males than females, as well as a really good distribution between race and ethnicities that were of interest to this study. So first, we were interested in whether our patient factors were significant predictors of PCC. So we had controlled in our first step of our hierarchical regressions on age, sex, with positive being female, and cancer status, with positive being ever had cancer before. And our second step of our hierarchical regressions were our patient factors. So we controlled for those first three variables in the first step. The results do confirm hypothesis 1, 2, and partially confirms 3, such that education is a negative predictor of PCC, income is a positive predictor of PCC, and identifying as Hispanic, Latino, Latina, Latinx is a negative predictor of PCC, whereas Black or African American identifying as that was not a significant predictor of PCC. I also recommend that you pause the video here as well. Our fourth and fifth hypotheses were associated with what PCC predicted in terms of these outcomes. So we included PCC in our hierarchical regressions. Again, first step, controlling for our control variables. And then those that are in bold and red are the significant variables. And you can see from here the interest of PCC positively predicts both health status and quality of care. Again, we were also interested in whether PCC mediated the relationships between the patient factors and our health outcomes, those being general health and quality of care. So you will see these on this slide and the next slide. Please pause the video if you'd like to look at these in a bit more detail than what will be presented. So at the p-value of 0.05, we see that PCC significantly mediated the relationship between education and general health, as well as quality of care. And the same results are found for income, right? PCC significantly mediated the relationship between income and general health, as well as income and quality of care. Moving forward, you can see that PCC significantly mediated the relationship between identifying as Latino, Latina, Latinx, or Hispanic, and general health, as well as quality of care. However, PCC did not mediate the relationship between identifying as Black or African American and general health or quality of care. So this shows that H6 is partially confirmed. Overall, this study contributes to the PCC literature. Specifically, it highlights specific patient factors that predict PCC, as well as looking at general health status and quality of care as outcomes of PCC, thus the mediating role of PCC. And lastly, we present a holistic PCC model that can be used for future research. This research also highlights the need for developing interventions that target PCC among specific populations, such as those with low income and minorities that had reported lower levels of PCC, because eventually this may result in helping address some of the health disparities that are apparent with these populations. Thank you so much for listening to this presentation. Here is my contact information as well as my collaborators as well. Enjoy the conference.
Kia ora. Thank you so much. That's a fascinating study of patient-centered communication and its mediating role in addressing health disparities. We now move to the next presentation, which is on leveraging latent class analysis to understand health information needs, motivations, and behavior in the population.
Hello, ICA. I'm Yue Li, a doctoral student in Communication Arts and Sciences at Penn State. And today I'm going to be talking to you about my project on leveraging latent class analysis to understand health information needs, motivations, and behavior in the population. So before I dive into my methods, I'm going to be overviewing some of the variables and theories that I'm going to be using to inform this analysis. So first are some of the predictors of health information behavior. So drawing from health belief model and theory of planned behavior, I think that demographic information, socioeconomic status, social relations, health status, and health efficacy, as well as trust and health information sources, these will predict how people interact with health information. And then the indicators that I will be using to build the latent class models are they fall into these categories. So these are information seeking, both in general and from social media, that people share content online, that people talk to their friends and family about health, that people use apps and devices to track health data, and that people interact with their healthcare systems online and electronically. And then we can also look at some outcomes of health information behavior. So drawing from theory of planned behavior, for example, we can look at how people interact with health information predict their perceived behavioral control or self-efficacy and their perceived obstacles in doing so. And also interactions with healthcare. So whether health information behavior can serve as predictors of people's tendency to avoid their doctors or their visit frequency, and also some perceptions of quality of care and patient-centered care. These are the outcomes that I will be looking at. So methods, overview of the latent class analysis approach. So it's a person-centered approach to latent variable modeling. So rather than making latent variables that are continuous, we make latent variables that are categorical and mutually exclusive. So the belief is that population can be divided into segments based on response patterns on observed categorical indicators. That's the basic idea of latent class analysis. And we usually go through several steps: model selection based on fit indices and ease of interpretation of classes. And then you go on to interpret the patterns of the indicators in each classes and give them names. And then lastly, if you have auxiliary variables, you can look at them. So these could include continuous predictors of health information behavior, grouping variables such as race, ethnicity, and also distal outcomes. So if you are familiar with path analysis, that will be the conceptual model that I will be looking at today. And then the overview of my data. So I'm going to be using HINTS 5 Cycle 3 data collected in 2019. This is the Health Information National Trends Survey administered by the National Cancer Institute. And this is a really rich data set. It's nationally representative and it's weighted. And in this data set, they primarily focus on surveying people's knowledge of and attitudes toward health and cancer-related information. Next is model selection. This is just to show you that the fit indices that I've looked at and the 8-class solution is the one that I landed on. Next are the latent class results. So as I mentioned, I selected the 8-class solution. So on each of the bars, you will see a red line, and that's the population average on that indicator, and that's constant across all classes. And the blue bar is the item response probability of that particular class on that indicator. And I'm gonna be going over the classes. So first is the power user class. They are a small fragment of the population, only 7% in the sample. And so they're the second smallest class. They are characterized by their higher likelihood to report all health information behavior and population average. So as you can see, all of the blue bars exceeded the red line. And because of that, I'm gonna be using them as the reference class in the auxiliary analysis. On the other end of the spectrum, the other extreme will be the disengaged. And that's a whopping quarter of the population, and that's the largest class. So these are the people that do not interact with healthcare in general. As you can see, across all the indicators, they are way below the population average. Between these two extremes are the passive health information users. So they're the second largest class, representing 23% of the population. And they're characterized by reports of low effort health information behavior. So things like they've visited social media, they've installed health apps, they've talked to friends and family about health, and they are below average on a lot of other things. The next class is what I call the passive trackers. They are 8% of the population. They have high prevalence on other tracking. So these are glucometers or digital blood pressure devices. My sense is that this is a group that is dealing with some sort of health condition, and they're prescribed tracking devices. And 50% of them do share their health data with their providers. But they are low on a lot of other indicators, particularly in the healthcare utilization block. Compared to the last group, the next group is called the active trackers. They also track their health data. They have relatively high prevalence on all types of health data tracking, and they are more likely to share their tracked data with the providers. And they also keep track of their test results and electronic medical records online. They have way higher utilization of healthcare information systems than the previous class as well. And the next class is what I call the active healthcare users. The most marked difference between this group and the previous group is that they were not prescribed any sort of tracking devices. Some of them do wear wearable devices like an Apple Watch, but they do not share their health data with their providers. They have high utilization rate of healthcare information systems. The next class is the passive healthcare users class. So they have above average usage of healthcare systems, but lower prevalence on other health information behavior, including general health information seeking, tracking, and active forms of engagement. And then the final class, which is also the smallest class, is the opinion leaders. As you can see, there are some full bars and then there are some empty bars. So this is a very well differentiated class. So they have the highest prevalence on shared health information on social networking sites, and they've bought medication online. They also have high prevalence on wearable tracking and prescribed tracking, but they are low on most other indicators. So this is indeed a very peculiar group, and you might find them interesting in some of the auxiliary analyses as well. So we don't have a lot of time left. I'm just going to go over some of the global trends I saw in these auxiliary analyses. So in my examination of predictors, I'm going to be using class 4, aka the power user class, as the reference class. Looking at some demographic information, higher age contributes to higher probability of being in the tracker classes, the passive healthcare class, and the disengaged classes. So that sort of makes sense because we know that your health risk increases as you age, and you might also feel less efficacious in terms of your management and interaction with health information. So that's a very intuitive finding there. Higher income predicts lower probability in passive health information users and the disengaged class, the two largest classes. Being insured predicts lower probability in being an opinion leader or being disengaged as compared to the power user class. Being married or cohabiting predicts lower probability of being in the opinion leader class. And being a caregiver predicts lower probability in most classes compared to the power user class. And moving on to the next set of predictors. Higher health efficacy predicts lower probability of being in the passive classes and the disengaged class. Higher trust in doctors for health information, very interestingly, predicts lower probability of being in the opinion leaders class. Higher trust in friends and family for health information predicts lower probability in all classes but passive trackers compared to the power user class. Higher trust in charity for health information predicts lower probability in being an opinion leader or disengaged. The other two trust variables, trust in government or trust in religious organizations, did not predict class membership. And then next, I'm going to be using the BCH approach to look at distal outcomes of latent classes. So these are mean comparisons, classes that share a letter do not differ in their means. The first outcome that I looked at was the frequency of going to a provider. For this outcome, the opinion leader, and the passive health information users, they were actually the highest in their frequencies of their visit to a doctor. And power users, active trackers, and passive trackers, they are actually the lowest in the spectrum. Moving on to their tendency to avoid doctor, though, opinion leaders, while being the most frequent visitors, they also tend to avoid doctors the most. They are really different from the active healthcare users and the trackers. Moving on to patient-centered care, higher scoring would be the trackers, and then the lowest scoring would be the active healthcare users, perhaps because they interact with healthcare more, they have more complaints, and also passive health information users. Moving on to the final two distal outcomes of health information behavior, health information efficacy and health information obstacles. For health information efficacy, the power user class, because they've done more health information behavior than the population, so it makes a lot of sense that they feel efficacious in doing what they do. The opinion leaders, they also think that they know what they're doing with their health information seeking. Compared to them, passive health information users, the disengaged, and the passive healthcare users, they are the lowest scoring in terms of their health information efficacy. When we move on to health information obstacles, you can see passive healthcare users and the disengaged, lowest scoring on health information efficacy, highest scoring on health information obstacles. That makes a lot of sense. But power users also did not differ from them, perhaps because they use it more, they have more complaints, and they're better able to see obstacles. The lowest scoring for health information obstacles are the active trackers and the active healthcare users, perhaps because they have greater access to their doctors, they talk to them more, they feel more efficacious, and they perceive fewer obstacles when it comes to gathering health information. So lastly, I will be briefly going over some of the next steps that I'm considering. So first is I will evaluate some of the latent class indicators to refine the models. Second is I will focus on a more refined set of auxiliary variables and potentially look at some other ones, including race and ethnicity as a grouping variable, because I really think that that will help us understand health disparities and device interventions. And then lastly, a comparison between the 2019 data and the 2020 data, which were collected right when we knew that we were going to be in this pandemic. So I hope to do that so I can examine whether and how the pandemic changed health information behavior in the population, whether the classes change, or whether the distribution between classes change. So thank you for tuning in to my talk, and I welcome any feedback, suggestions, questions that you have, and feel free to email me at uwhaley@psu.edu. Thanks for watching.
Thank you so much, Yue. A fascinating way to look at principles of segmentation as it relates to patient-provider communication, as well as efficacy and obstacles. We will now move on to the next paper, which is Misperceptions of the Prevalence of Health Conditions and Behaviors by Jiawei Liu and Jeff Nader-Depe.
My name is Jiawei Liu. I'm a postdoc associate in the Department of Communication at Cornell University. I'm presenting the paper that I co-authored with Dr. Jeff Nader-Depe, titled Misperceptions of the Prevalence of Health Conditions and Behaviors. Many health problems and health behaviors are common in the United States. For example, health problems such as obesity and diabetes, health risk behaviors such as cigarette use and binge drinking, and disease screening behaviors such as colorectal cancer screening and breast cancer screening. So news stories and health campaigns often feature these health issues to highlight their widespread impact to raise people's awareness of these health issues. But little is known about whether people have accurate estimates of the prevalence of these health issues and the related racial health disparities, which then becomes the main purpose of our study. People's perceptions of the prevalence of health problems and behaviors, whether accurate or not, hold the potential to influence people's attitudes and behaviors. Sometimes misperceptions have negative behavioral consequences, but it is not always the case. For example, overestimation of the prevalence of health problems may also be positively associated with public support for related policies to deal with those problems. On the other hand, social norm theories suggest that the more you perceive other people perform a behavior, the more likely you will adopt that behavior yourself. It could be a behavior that is harmful to your health, such as cigarette use or binge drinking, or it could be a health promotion behavior, such as cancer screening. Therefore, it is very important to know whether people have accurate estimates of a wide range of health problems and behaviors. Also, one of the most common indicators of health disparities is the difference between the prevalence rates of a health problem or behavior between specific population groups. Race remains a prominent source of such health disparities. Prevalence perceptions of health problems and behaviors may be partly shaped by and reflect these racial health gaps. Therefore, white and Black Americans may differ in their estimates of the overall prevalence rates of diseases and health behaviors in the United States. Whether people perceive differences in the prevalence of health problems and behaviors by race also has important implications on public support for policies targeting at reducing racial health disparities. If people tend to underestimate prevalence-related racial health disparities, then messages that include race-specific prevalence information of health problems and behaviors might make readers more supportive of policies that narrow racial health gaps. By comparison, if people tend to overestimate prevalence-related racial health disparities in the first place, then exposure to accurate race-specific prevalence information might decrease their support for policies addressing health disparities. Therefore, we ask the question, do people have accurate estimates of prevalence-related racial health disparities among white and Black Americans? It is also important to investigate whether respondents' estimates of racial health gaps between Blacks and whites differ by their own race. On the one hand, as the prevalence rates of health problems such as obesity and diabetes are higher among Black Americans than white Americans, Black Americans may be more attuned to the risks of these diseases and related racial health disparities. On the other hand, the idea of unrealistic optimism in social psychology suggests that individuals tend to have self-serving and self-enhancing biases in underestimating their own level of risks. Therefore, we ask the question, do Black Americans and white Americans differ in their estimates of prevalence-related racial health disparities among white and Black Americans? We have an analytic sample size of 395. About 50% of the respondents were non-Hispanic white adults, and 50% of the respondents were non-Hispanic Black adults. As listed here, we measured perceived prevalence of health problems, health risk behaviors, health promotion behaviors, disease screening behaviors, and vaccination adherence. And we also calculated perceived racial prevalence gaps. As we can see, people are more likely to overestimate the prevalence of health problems such as obesity and diabetes, and health risks behaviors such as cigarette use and binge drinking. By comparison, people are more likely to underestimate the prevalence of health promotion behaviors such as diet and exercise. And they are also more likely to underestimate the prevalence of disease screening and vaccination behaviors, such as breast cancer screening, colorectal cancer screening, and HPV vaccination. And as you can see, whether people have accurate estimates of prevalence gaps is highly dependent upon the specific health problems and behaviors in focus. Race is a significant predictor of perceived prevalence gaps. For example, for obesity, white respondents perceived no significant prevalence gap, but Black respondents perceive obesity as more prevalent among Black Americans than white Americans. For binge drinking, both white respondents and Black respondents perceived it as more common among white Americans, although Black respondents rate the gap as larger than white respondents. Findings from the study offer a variety of potential implications for the use of prevalence information, as well as race-specific prevalence information in health news stories and mass media campaigns. First, people tend to overestimate the prevalence of health problems in the United States. Some forms of misperceptions, for example, overestimation of disease prevalence, could have potential to serve in the interest of public health by increasing perceived disease susceptibility and support for policies to address it. However, the same patterns of association also raise the possibility that messages featuring accurate disease prevalence rates could also unintentionally dampen policy support by reducing people's estimates of their disease susceptibility. Second, people also tend to overestimate the prevalence of health risk behaviors, but underestimate the prevalence of health promotion behaviors, cancer screening adherence, and vaccination adherence. Overestimating the prevalence of health risk behaviors could make people more likely to engage in cigarette use and binge drinking. Systematic underestimation of the prevalence of health promotion behaviors might make people less likely to follow healthy diet, exercise, or adhere to cancer screening and vaccination guidelines. Third, people's estimates of the direction of the prevalence gaps were largely consistent with the actual disparities, the only exceptions being for muscle strengthening activities, mammogram tests, and HPV vaccination. For both mammogram screening and HPV vaccination, respondents perceived these behaviors as more common among white Americans, whereas the actual prevalence rates showed the opposite. Finally, race is a significant predictor of perceived racial health disparities in 5 out of 14 health problems and behaviors. But the extent of the differences between the estimates made by white Americans and Black Americans were relatively small. Therefore, results suggest that white respondents and Black respondents had largely comparable estimates of prevalence-related racial health disparities. Thank you.
And we will now move on to the final presentation, and this is by Dr. Phoebe Elers.
Hi, my name is Phoebe, and my presentation today is titled Receiving Healthcare While Lockdown, Voices from the Margins in Aotearoa, New Zealand. And as the name suggests, my study is about experiences and perspectives of receiving healthcare during the COVID-19 lockdowns in Aotearoa, New Zealand in 2020 among community members who are situated in the margins. So delivering healthcare effectively is a key challenge during the COVID-19 pandemic. On the one hand, there's the need to ensure the safety of clients who are receiving healthcare, but on the other hand, there is a need to ensure timely and effective healthcare delivery in a time when there's increased public unrest. So virtual healthcare delivery has been suggested as a potential solution to providing safe and timely healthcare during the COVID-19 pandemic. Aotearoa, New Zealand utilised virtual triaged consultations during the COVID-19 lockdowns, which basically meant if someone needed to receive primary healthcare, he or she contacted their healthcare provider, a time was set up for a virtual consultation over the phone or via a device, and the healthcare provider attempted to resolve the issue remotely. And if a prescription was needed, this could be faxed to the local pharmacy. So in-person consultations only took place if absolutely necessary. And this was coupled with Healthline, which was a free toll-free number where people could get COVID-19 health information and advice. Research conducted with people who received healthcare during the first lockdown determined that this delivery could be as good or even better than in-person care, and actually concluded that this form of healthcare delivery should continue as an option after the COVID-19 pandemic. However, this research was underrepresented in ethnic minorities, and no research has examined how this was received by low-income ethnic minorities. And this is a really important research area because ethnic minorities have increased risk of infection and mortality from COVID-19, but are also traditionally less likely to adopt technologies for healthcare. So the present study explores experiences and perspectives of the healthcare delivery during the COVID-19 lockdowns in 2020 among residents in a low-income suburban area with a high proportion of Māori and Pacifica peoples. The study is guided by the culture-centred approach. It is actually part of a broader project that began in 2018 and is continuing to this day. The culture-centred approach methodology basically works with people who are situated in the margins to identify issues with health and well-being and co-develop respective solutions. So in this phase of the project, 32 interviews were undertaken with participants who are Māori, Pacifica and other non-white ethnicities. Most participants weren't employed. The vast majority were well aware of this new delivery, and 21 of the 32 participants received healthcare during the lockdowns, and that was for either themselves or for someone that they were caring for, such as, you know, a child or a elderly family member. And what we found was that this new system was characterised by increased waiting times from, you know, calling the toll-free number to the phone consultations to the in-person consultations. So as one participant stated, I received healthcare for my asthma, my depression, my experience was terrible, the long wait just fed up. We're standing outside 2 metres apart in the hot blistering sun, that's one. Can't use the toilet, that's number two. So the increased waiting time heightened frustration and anxiety, especially among those who thought that they may have contracted COVID-19. And the second key finding concerned the mediated or virtual delivery. The vast majority of participants preferred, the previous in-person consultations compared to the new modes of virtual delivery. Here's what one participant stated: "I was getting brushed off. They were just like, here, let's give you these typical creams." And it was like, no, I want you to listen to me. I'm in pain. I want to be able for them to see what I'm going through. So as this quote suggests, there was a widespread concern that clinicians could not diagnose accurately through mediated delivery. But further to this, people felt that they weren't being listened to through virtual delivery. And there was a preference for face-to-face communication, for establishing relationships, and for effective communication that was at odds with these new modes of healthcare delivery. And the final finding we titled individualised care. So an inherent issue with the virtual delivery was that people couldn't have support people outside of their households for the virtual consultations, and often couldn't have support people for in-person consultations. This increased language barriers for those with low English fluency who are used to having family members help them with this during consultations. But once again, it was also not in keeping with the cultural norms of the area, where people often support one another during these appointments. So here's what one participant stated: "It was only him allowed inside the room. They just said it's just for their safety, the patient's safety and our safety." She's referring to her 14-year-old son. I was arguing, like, you shouldn't check on my son without a guardian. So taken as a whole, the new modes of healthcare delivery during the lockdowns have the potential to further reify and reproduce exclusions and experiences of marginalisation. Our study has provided an alternative standpoint of the virtual healthcare delivery during the COVID-19 lockdowns. This is not to say that the virtual delivery was not necessarily justified, but what is largely erased in the representation of Aotearoa New Zealand's COVID-19 measures is the voices of those who are situated in the margins. Thank you.
Okay, that completes the 4 presentations in this section, Health Communication for Health Disparities. And let's open up the floor to questions. I wanted to make a broad commentary about, this notion of patient-centered communication that emerges from the first there's 2 studies, and would love to hear your thoughts on it. So basically, what those studies are suggesting is that when we have greater patient-centered communication, that seems to be a way of addressing quality of healthcare. And, like the first study suggested that patient-centered communication mediates the relationship between education, income, race, and sort of the quality of healthcare. Would love to hear your thoughts about this. So patient-centered communication, in a nutshell, suggests that it's the efficacy of the patient to participate in the interaction and to drive the quality of care based upon the patient's participation. What do you think?
Well, I can ask a question then, especially from the point of culture-centered approach. If the patient and the health practitioner belong to different cultural groups, especially like within the society, say the patient belongs to the marginalized, say ethnic minority, how this approach would enable the patient to feel confident in sort of telling the health practitioner from their point of view, their own perspective on their health, because quite often that may be difficult for people who are coming from the communities that feel not fully listened to by health practitioners.
So I suppose that that's a great point, Elaine. And I think, thanks for sort of placing the culture-centered approach in dialogue with this. And I think the CCA would say two things. First of all, it's that creating those spaces for marginalized communities that are typically erased to be heard, is potentially a good space. So in that sense, education and training on patient-centered communication, both for communities so that they can advocate and participate, as well as for providers so they learn to listen to those cultural differences and pay attention to the voices of patients, diverse patients, could be important entry points. So that's one level. But also the culture-centered approach would say that that kind of sort of empowerment is situated in relationship to structures, meaning that provider-patient interaction is embedded within a larger structure of health disparity and health inequality, and that without addressing that structure, we won't really be able to see large-scale changes. So that means that sort of that kind of patient-centered communication needs to be complemented with or supported by large-scale movements and structurally based processes of change.
Yeah, thank you. Yeah.
Did you all have any comments?
So I have one question. In case of patient-centered communication, is there any country where that this model is followed, patient-centered communication? Because I know its communication is physician-centered communication or doctor-centered communication.
Yeah.
So is there any country like where patient-centered communication is actually followed?
That's a great question, Mabu. And I think there's a global movement right now in biomedicine more broadly toward patient-centered communication, beginning from the recognition, particularly in the backdrop of health disparities, where you see these large-scale health inequities within populations, that you cannot really address these inequities without having the voices of patients and patients participate in the process. So there is a large-scale global movement. There are sort of the Institute of Medicine guidelines now on biomedicine need to be practiced along the lines of patient-centered communication. Certainly, different countries have taken up that model in different ways. Like in the US, we have, with President Obama, when he was elected with the Affordable Care Act, he introduced the PCORI centers, which are patient-centered outcomes research initiatives, the goal of which was actually to address health disparities by centering patient-centeredness in the whole biomedical process. We also see certainly that, TEROA with an emphasis on patient communication and patient-directed care. So it might take different languages. We see it within the context of NHS. But you also have to think of it within the broader framework that as this has happened, healthcare has become more and more privatized, right? So a critique of this is that even as we talk about patient centering, it becomes a way for placing the responsibility on the patient while really privatizing healthcare and depleting that structure. And I think, one of the things that COVID makes clear is that we definitely need those structures and we need to make those robust. How do you do that? While centering patients' participation and at the same time not depleting these resources, I think is the real challenge, Any other thoughts about any of the other papers?
Yes, I can just add here in terms of virtual healthcare delivery. It's also can indicate how patients from different economic levels can use that
Yes.
or completely miss out because they don't have capabilities, they don't have digital devices, they don't have, say, privacy in their homes to discuss their health issues, so they may feel like during our lockdown, people were stuck and like because no one knew for how long it's gonna be, so many families moved in back together. So suddenly there was a question of privacy, especially in terms of healthcare. And that's why I guess many people would delay even just the consultation that could have been conducted by virtual means. So in that case, obviously people from high economic levels, they're privileged in utilizing. And I think the request to keep using that probably comes from this income group rather than from people from low economic social status or from different ethnic minorities.
So again, going back to our conversation on the portals,
Exactly.
the inequalities the digital inequalities become really visible, and they actually play out. And that's not just access to the technology and its modality. It's also about, like you're saying, where people inhabit, where do they live, how do they live, and
It's like in the beginning of the pandemic when so many countries went into the lockdown and lots of people started complaining, and then other people would say self-isolation is a privilege. So for many groups in society, even in such countries like Aotearoa, self-isolation probably was not possible for people from low income status.
So this thing about the waiting time, that was really prominent. That people would say that they would have to wait, and even if you had, say, fever, and the initial guidelines was that you're supposed to call in this triaging facility, and people would say that they waited and waited, and then they gave up. They just hung up the phone. And that also really relates to the question of infrastructure. So what is the kind of infrastructure that you have that is able to address the needs, and who is that going to miss out on? Stephen, did you have anything to add?
Not broadly. There were a couple of the statistical papers I was a little confused on, but that's just, I'll read the papers, but there are things I was just wondering about in the tables. I didn't understand some of the things. And I would ask them if they were here, why were they reporting this and not this, or this and that? But I'll look at the papers and see if it's in the paper instead. Those are my larger kinds of questions, particularly when they're doing that kind of latent analysis, that model analysis and hierarchical regression. There are a few things that stood out to me in that way, just from a methodological point of view. That seemed a little different, I'll say.
Frankie, did you have anything to add?
Well, I was just thinking, with the health systems being so much under pressure, and everybody's so rushed with everything, and you're looking at the patient-centered communication, is there time for that? because everybody's so rushed about things. You know, it's just, especially with COVID as well, where hospitals and clinics are just so, it's almost just looking after it's a diagnostic thing, quite a clinical thing. I don't know, just how does that fit in with the PCC, or how does the PCC fit into the system? And even if you've been trained in that, and in a lot of medical places are understaffed as well, and medical staff are really under so much pressure, working so many long hours, that it's literally just getting the patient well. Even if you've been trained in PCC, it could still just slip away.
Yes.
Especially under pandemic situations or normally very busy situations. Yeah.
Right. Which again goes to the broader question of structure.
Yeah.
Going back to Elena's. So, you know, our culture-centered intervention in that sense would actually say that we need to advocate for how do we change our healthcare structures, you know, and would really ask the question of, so that nurses can get paid, so that doctors can have enough time, so that we have more doctors within the systems, you know. So because in some ways, you know, one of the critiques can be that PCC is a way for the neoliberal model of organizing healthcare to place more onus on the health worker, who now not only in addition to seeing more patients has to make sure that they are being patient-centered, and so it turns into individual pedagogy and education while really constraining the capacity of the healthcare system.
Very much so.
I was going to say that's what could concern me, is that if you look to the healthcare system, the healthcare workers have some of the highest suicide rates, some of the highest depression rates in the world. And then my concern would be, imagine if we had a system. Imagine all of a sudden if, you know, Aotearoa said our system, our healthcare system is going to be patient-centered. And so now all of our doctors and nurses and others have to retrain, learn X, Y, Z, A, B, C, and D. I could see a lot of people, a lot of doctors and other healthcare professionals loving that and already doing things similar. But I wonder, to what extent could that also put extra pressure on some of our healthcare professionals that is unneeded in that way, already strained? And so I wonder, that would be an interesting way to look at this, is really look at, I think I agree with the PCC, but I also think we need to remember that medicine is, I mean, there's the difference between like patient-centered and the human side of things. There's also the medical side of things as well. I know the two connect. I recognize that. But there are going to be times when I wonder, just also from a practical point of view, I don't know if it has to be one or the other. I would just wonder from a practical sense, is that'd be my concern. If we go entirely PCC, I don't think that's the way to go. And I don't think we can stay exactly where we are now. So I think that needs to be looked at, because I think economically going entirely that way will cripple systems and even cause even more problems when it comes to access, because we won't have enough staff, we won't have enough beds, we won't have enough anything to go that road. But if we go the totally opposite route, it's just complete, like basically may as well just have robots doing things for us and just have basically like a McDonald's healthcare system. And so we need something right in the middle that also recognizes patients there, but also recognizes a provider centered as well, in the case that providers are also human beings who also can't be everything. And we can't expect everything. And I think sometimes we have wonderful ideals and wonderful theorizing, but they put too much onus on one group sometimes and not enough on both groups. And it's unrealistic.
And also not enough on structures. Because, you know, if you were to interview providers, be it nurses or doctors, they would say that actually we want to have, you know, a very simple thing. We want to have more time to say, like what you're saying, to see a patient. You know, so say for instance, when you go from a consult that is 45 minutes to actually touch the body, see, have the face-to-face contact, which naturally that structure enables for that dialogue and patient-centeredness for the provider to engage dialogically to a structure that is saying your consult going in and coming out has to be 15 minutes. And then you're penalized if your consult time actually increases, right? So,
but I would worry if we go down the road. I'm not saying you're going down the road where if a doctor, a state doctor, isn't practicing a PCC approach or isn't going this way, they're not good. That would concern me because I would say one of the best surgeons I've ever had was at the worst bed manner, no dialogue whatsoever when it came to things. It had to be done, but the best surgeon. And so my feeling is, you know what? He was the best at what he did scientifically and medically. I don't care if he was going to talk with me and care what my feelings were.
Right.
Because he took care of the issue.
Actually, yeah.
And that was all I cared about. He kept me alive.
Right.
That was more important than him caring about what I think, dialoguing with me, my feelings, anything else. He saved my life. He saved other people's lives. That's so we also have to take those things into consideration too. Is really part of me would rather have a cold-hearted brain surgeon doing something than someone who's maybe we can have that warm, lovely, patient-centered brain surgeon who does great things. But if we don't, I'll take the one who's cold-hearted and then someone who's average but a person-centric.
Right.
So we have to balance those things.
Right. And I think, where this literature comes from is sort of at a macro level, right, outside of anecdotes, when you look at sort of population-wide relationships, what you find is that a doctor is more effective, or biomedical healthcare is more effective when it attends to patients' participation. And particularly in the context of health disparities, because there's a lot of research that says that the kinds of conditions that are brought by underserved communities don't get heard or don't get listened to in terms of, say, symptom taking, which then actually leads to poor quality care being delivered. So I'll give you a simple example. Say, for instance, there's a lot of research in the breast cancer domain that says that Black women's reporting of symptoms don't get listened to and taking note of adequately, so that actually the screening doesn't take place, which then relates to poor health outcomes over the course of time. So I think the notion of patient-centeredness in that sense, Stephen, very much aligns with the ability to deliver better biomedicine if you're actually listening and attending to symptoms and not letting your biases work through.
That's why you need that
balance.
Yeah.
Anything else? Anyone wants to jump in and add anything else, or are we feeling that we are ready to wrap up? Okay, we are good to wrap up then. Tomorrow we have a busy day once again. We have a few panels tomorrow, and let's quickly walk through that. So tomorrow we are going to start with you, Melissa, with your escalator, research escalator presentation in organizational communication division. Then we are going to go to you, Mahbub, to talk about your Rohingya refugee work. Then we are going to have the ICA closing plenary from 12 to 1:30 p.m. So for our global audience, please tune in for that. And then we have the Blue Sky workshop on a conversation with editors of journals, the art of short papers in instructional communication, that Stephen is going to lead from 1:30 to 3 p.m. Okay, thank you so much once again, and see you tomorrow. Bye-bye.